Hello, ladies and gentlemen, and welcome to the 15th and final meeting of the Big Health and Care Consultation Oxfordshire Transformation Programme Phase 1, and welcome to the Crown and Thistle Hotel and Pub here in Abingdon. An unusual setting, but I think it's pretty good, pretty cosy for where we are. My name's Gavin Gray. I used to live actually in Abingdon and elsewhere in Oxfordshire when I was working for Central Television and ITV. I'll be hosting and chairing tonight's meeting. I am not a doctor. I do not work directly for the NHS, but it is my role tonight to get as many voices heard from residents today, from everyone here as possible. And we'll do that in a number of different ways, and I'll explain how shortly. Hopefully with a nice and smaller crowd tonight, we'll be able to get absolutely everyone's question heard. That would be really ideal. There are a number of ways in which we can do that, and as I mentioned, I'll come around to getting that. Just a few very dull housekeeping points, first of all. No fire alarm is planned. So if it goes off, that's the door, and that's the door. Not through the bar, apparently, there, and there is an assembly point out in the car park. That's an easy one. Toilets are out through that door and through the bar and keep going. Also, this is no smoking. If you've got a mobile phone, if you could turn it off or mute, that would be great. This is a public meeting, and I say that because that means journalists could be here, but it also means every word is a matter of record. So it is all being recorded. There is an audio loop, and in fact, it surrounds the whole room. So anyone that needs the audio loop can tune in or see our AV, audiovisual guy over there, just to sort that out. And there is a recording being taken as well. So as I said, it is a matter of record. So what we'll do is I'll get the panel members to introduce themselves first of all. There are a few seats over here. Just wander across when you're ready, or on that table. I'll get the panel members to introduce themselves. Then we're going to hear a short presentation. Now, some of you may already know plenty of what's in the consultation. Some of you won't. So it won't take very long to go through the presentation, and it'll be very useful, I think, that's been the feedback anyway, very useful for people to then formulate questions, concerns, raise alternatives, suggestions, proposals, ask for further detail from our panel. And then we'll break into smaller groups. I'm aware that some people do not like standing up in public and talking, so we'll break into smaller groups, round tables, and on each table will be somebody from the NHS team and possibly a doctor, not for a consultation, just to be there to sort of get your views, and at which point we'll then, shortly before the end, or when people have gone and felt they've had enough on each table, we'll just sum up the main points from each table to see how each group got on. We've obviously got this for a couple of hours, so we have to be sort of done by 8:30, but hopefully that's plenty of time for that. I'll finally just ask the panel to sum up after that anything that they've heard from what's come up from the round tables or the questions. Okay, so let's crack on. I wonder if I can ask the panel just to introduce themselves. It's a bit cramped, and they are blinded a bit by that light, so once the presentation's done, and the panel may shift around, I'm going to turn that off so that they're not blinded by the light. I hope that's okay. All right, and if I could ask then just to start the presentation, or rather, actually, let's do the introductions first of all. I'm getting ahead of myself. Start off at this end of the table, sure. And Gareth Kenworthy.
Sure. Good evening. My name's Gareth Kenworthy. I'm the Director of Finance at the Clinical Commissioning Group. So I've been a resident of Oxfordshire for about 20 years now, and for almost all of that time, I've worked in the NHS locally.
Can everyone hear that? Great. Yep, sorry.
Hello, I'm Julie Anderson. I'm a local GP. I've been a GP for many years at Burnsfield, and I'm the South West Clinical Locality Director for CCG.
Hello, my name's Tony Barrett. I'm the Medical Director at Oxford University Hospitals NHS Foundation Trust, where I'm the board lead for quality, among many other things. Lived in Oxfordshire for over 30 years now, having trained here and done my specialist training and had my whole consultant career here.
Good evening. My name's Andrew Stevens. I work with Tony at the Oxford University Hospitals NHS Trust, where I'm the Director of Strategy and Planning. That means I work with our clinical colleagues as well as colleagues in other partner organisations to develop plans and strategies for our clinical services. I've been in the NHS for 34 years, and half of that has been in my current post in Oxford.
Okay, so mixture of clinicians and a good broad mix of experts. We're just asking for that door. Is it possible to shut that door between the bars? Is that what they're going to try and do? Brilliant. Oh, brilliant. Thank you very much indeed. Lovely. Okay, so with that, if we can start the presentation, and I'll ask Gareth to come out. I think you're going to stand up or do it on one mic there.
I'll stand here.
In that case, you're going to need that.
Okay. I'll try and stand out of the way. I'm not the most inconspicuous person you've ever come across. So, are you okay? You don't need to see it. You've seen it before. I'm going to give a really, really brief introduction to the what and why about being here this evening. Before I hand over to Dr. Julie Anderson to talk in more detail about some of the specific changes we're proposing as this part of the consultation exercise. We've covered the agenda. This is the first bit I'll touch on. We've been conducting this exercise since midway through January. It's just short of 3-month exercise. As we've touched on, this is the final consultation meeting, so the challenge is to make this a high-impact meeting to round it off, but the actual consultation exercise is open until the 9th of April. We're consulting on a number of specific proposals that are listed there, and again, I won't go into the detail of those because Dr. Anderson will touch on those. We have got a second phase of work, which is planned for later in the year. That will cover a broader range of healthcare services. So we are open to listening to your views on those services this evening. It's just that we may not be able to respond to some of the specific detail in that, because that work is only just underway. Why are we consulting then? So here is a summary of our case for change. Again, I'm not going to go into this in any great detail. So we've got time for questions, and we've got time for table questions as well, where you can unpack this in more detail if you wish. This is our local view, but if you've been watching the TV, reading the papers, listening to the radio, over at least the last 3 months or longer, so you'll recognise this as being a national problem as well. So one of the key reasons why we are consulting, or why we want to make changes, is that we really believe that we can improve the quality and safety of healthcare services in Oxfordshire. Okay, medicine and healthcare moves on in leaps and bounds all the time. Okay, so we really believe that on that basis there are a number of changes we can make, and then improvements we can make to local services. A key one from my perspective, as you might expect, being the Director of Finance, is the one around funding. So we know that funding is not keeping pace with demand in the NHS. So our population is growing from one perspective, and our population is ageing as well. So there's those changes in the demographics, there's an increasing need for healthcare services. From a CCG perspective, our funding levels are growing for the next few years on average at around 2% per annum. But already we're seeing demand for healthcare services increase at a much larger rate. So I think year on year at the moment what we're seeing for services like A&E, we're seeing something like a 6-7% increase in A&E attendances on a year-on-year basis when we compare that. So you start to get a feel for the kind of gap that drives between the resources we have and the needs of the population. Inequalities also exist across Oxfordshire. So the example that we've quoted previously is one from the city, more from this area. But there's something like an 8-year difference in life expectancy between different wards within the city. So again, it's an ambition, it's an objective of this exercise to start to tackle some of those issues. And the other thing is, so I mentioned money already. The other thing is, if money wasn't a problem, then the bottom bullet point would be as well. So even if we had the money and the resources, it's clear in a number of areas we don't have the workforce to staff the services. Okay, and we'll touch on that a bit more as we go through the presentation. As we've been around the county, this question has come up a number of times. So why have we split the work into 2 phases? What we're consulting on now is phase 1. Phase 2 work is underway, and I think the ambition is to consult on that mid to late autumn. The slide deals with the rationale and the reasons for that split in the work. So there are some areas of services that need urgent changes. So the proposals around the changes to the acute hospital beds, we've been advised to consult as soon as possible by the County Council's Health Overview and Scrutiny Committee, which is why we're dealing with that at the moment. There are specific issues on the workforce point around maternity services at the Horton that link to the quality and safety of those services that are provided in the north of the county. And we believe we can make real improvements in critical care and stroke services. Okay. And then the final slide that I'm going to talk to before I hand over to Dr. Julie Anderson is the vision, really. So, again, the slide speaks for itself. We really want to improve services and avoid admissions to hospital wherever possible. If we can't avoid those admissions to hospital, we want the stay in hospital to be as short as possible, i.e. people to only be there for the time they need. And the point at the bottom speaks to that, really, in terms of the impact of longer stays in hospital, particularly on the elderly, in terms of the decompensation. And we think the NHS, both nationally and locally, needs to utilise technology much better. Technology is coming on in leaps and bounds. It feels like it changes almost daily. For those of you who have to keep up with mobile phones for your children. But there are aspects of those changes in technology that will bring real benefits to the delivery of healthcare. So again, that's something we really need to build into our work. Okay, I think at that point, I hand over to Julie.
Thank you. If I stand here, am I blocking the slide? Yes. Thank you. So Gareth has already described the points in general, and I'm just going to go through some of the specific areas and outline them in a little more detail. For most of the areas, there's a video as well, so I'll make my introduction fairly brief and let the video speak for itself. But I think the first one on using hospital beds differently is one where, as a GP, I've seen the potential for that over many years. I've been in general practice for, as I say, nearly 40 years, and of course, changes have happened throughout that time. Hospital stays have got shorter. Many things are done now as day cases that were previously requiring a week or two in hospital, and many things are done as outpatient procedures or indeed even in the community. So change is not new, and we've had to continue to innovate in the NHS in order to respond to the challenges, but also because it makes better sense. People get better quicker, and it's better all round. But with using hospital beds differently, I think that what we've seen over the more recent years is the challenge of how we might manage people who are elderly and need short episodes of care, but who go into hospital, and those episodes of care often turn out to be far longer than are needed. So we really need to exploit the ways in which this group of people can be managed more expediently in the community. And certainly as a GP, I've had many instances where patients have not really wanted to go into an acute hospital bed, and I have known that there would be alternatives if services were configured differently in the community.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, well, just thought it'd be good companionship for you, nice and sleepy together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The liaison hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The liaison hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
So that's one example of how patients can be helped to move on and into their rehabilitation as quickly as possible. And of course, in Abingdon, most of you probably know there's an emergency medical unit which has provided an alternative to an acute hospital admission at the John Radcliffe for some years now, which focuses very much on an ambulatory pathway, in other words, not an admission, not an overnight stay, or if there is an overnight stay, a fairly brief one with intensive treatment and follow-up either in the patient's home or back at the community hospital. And this model has actually shown that many patients who would have normally been sent to the John Radcliffe can now have an alternative, more rapid access to care and a speedier recovery as a result. And of course, it's not just elderly care. This is a service which is open to people of all adult ages. So moving on, planned care. So planned care is everything that is not emergency care. So when you see a GP and it's decided that perhaps you need a specialist opinion, then a referral is made, and that's all planned care. So it's where a GP has usually written a referral letter. The planned care is care. So I'll just hold that a minute. So before we get into the video, the planned care changes are, again, ways in which you can develop services so that people can have day case treatment and other processes of care delivered more effectively nearer to home. And this is specifically around the Horton, but there's a general principle that applies throughout the county here.
Planned care is care that occurs outside of an emergency situation, and the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations, and if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis.
You can concentrate. All right, good for you. We'll carry on then.
Planned care is care that occurs outside of an...
You're going to have to either listen to it again or miss the end of it. I don't think there was a lot more in it. What do you want? I think we should... Okay. So I think as a summary... As a summary, I think the idea is to have more planned appointments and tests and treatments available at the Horton General Hospital. And, of course, that will increase capacity across Oxfordshire, including for people in the south of the county who would still access their local hospital at the John Radcliffe. There's definitely a tendency, a move towards increasing the diagnostic facilities available generally so that more things can be... more conditions can be managed in the community. As the figures say here, it means that more patients can be assessed and treated locally. So the data is suggesting 60,000 extra outpatients and 30,000 day case and diagnostic appointments each year at the Horton General Hospital, which is a big increase in capacity, and for that population, a considerable saving in travel time. Stroke care. So there have been a lot of changes in the management of acute stroke. So this is the stage when someone's just had a stroke, where early intervention can make a huge difference in terms of outcome and reducing disability. And the prompter that urgent intervention, the more likely there's going to be a better outcome. And there's two types of acute intervention. There's a treatment which has been around for some years, which is a clot busting treatment, an injection which helps dissolve the clot, but more recently a mechanical technique of allowing the clot to be retrieved from inside the artery and the blockage which is destroying that part of the brain affected being removed. So fairly dramatic stuff, very clever technology, but it needs to be concentrated in a very few skilled hands. In Oxfordshire, we've had acute stroke care both at the Horton and at the John Radcliffe. Only the John Radcliffe has provided the hyper-acute stroke service, which is where people have the stroke dissolving treatment and where they will now have thrombectomy. So the proposal is that anyone with an acute stroke would be transferred to the Horton, wherever they have their stroke in the county, to the John Radcliffe. Because that is where those facilities will be concentrated. It's also known that rehabilitation and outcome is improved if people have their treatment in acute stroke units which are large enough, with enough of a throughput of patients to maintain the skills in the whole stroke team. So, in other words, larger stroke units have better outcomes than smaller stroke units. The stroke unit at the Horton has been traditionally quite small, and the changes that are being proposed would mean about 120 patients a year are transferred directly to the John Radcliffe instead of going to the Horton. But, of course, they would be able to go back to the Horton for post-acute stroke care. And acute stroke care covers the first week or two. Post-stroke care and rehabilitation covers the period beyond that. And this video will just go through that. Those are the key features. I will just mention that the early supported discharge service is a service which enables people to continue their rehabilitation once they've gone home. So they have stroke-enabled therapists who visit them at home, provide physiotherapy, occupational therapy, or speech therapy for a defined amount of time over a defined period to get the best possible outcomes for such patients. We seem to have lost the video around stroke care, but I think I've summarised the key points. Critical care is what used to be called intensive care, and there are different tiers of intensive care. The proposal around this is that those who need the highest level of intensive care, which is tier 3, which will include ventilation, mechanical ventilation, that this group of people who again need the technical expertise that's best available, that they should also be moved to the John Radcliffe, and it would not be provided in the Horton, although tier 1 and tier 2 critical care would be. These are relatively small numbers of patients affected. And the transfer of such patients would be accompanied by the appropriate specialists while they're in transit. Maternity is, again, focused on the Horton. There's about 1,500 deliveries a year in Banbury. That works out about 5 a day. And the difficulty, as you probably read in the paper, in maintaining that service for such a small number of people is the difficulties in recruiting consultant obstetricians and specialists to stand by for the odd patient, the occasional patient who needs that level of intervention. Many of these patients can be predicted and their delivery arranged in the John Radcliffe in advance. But with a general shortage of consultants obstetricians, it's become increasingly impossible to maintain a dual service both in the Horton and at the John Radcliffe. And this video that I'm about to show you will go into that in a little more detail.
We want to provide a high quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of 2 groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex And actually, as the health service has developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
So the changes that are proposed in the Horton would mean that the Horton will have a midwife-led unit. Women up in the north of Oxfordshire will have the choice of going to some of the hospitals across the border in Northampton and Warwickshire, and in fact some of that group actually come down south to the Horton at the moment, but they would go to their local hospital. There will be their choices of midwife-led units as well in the south of Oxfordshire, as you know, and the travel times for people from the far reaches of south of Oxfordshire were very similar to those from the Banbury area. I think that although there have been some concerns that the transit time is an obstacle, in fact, there's very rarely an instance where someone cannot be transferred safely from all the parts of Oxfordshire if their transfer is required. This would mean that the special care baby unit at the Horton would also not be required. And as the key point at the end is that this is about ensuring that there's enough staff to maintain a consultant obstetric service with a 24-hour presence in Oxfordshire all the time. I think that's the end of the particular examples. There's more information on the website, and this goes through some of the ways in which you can, if you think of things afterwards that you want to feed back on, the ways in which you can do it. But I'll hand back to Gavin at this point.
Julie, thank you very much indeed. You want to come back in? It was difficult enough to listen to, but very well done for getting through the presentation, because that was very difficult in that fire alarm going off. So there's a gentleman who's standing at the back. There's a seat here if you'd like. You're okay there, great, okay, and there's another spare one over here. Okay, so you've heard an outline of the presentation. Brilliant, thank you. The document that you've all got on the table has much more detail about all the points Julie's just been making. There are some postcards on each table. Now, if you don't want to stand up and ask a question of the panel now, there's the opportunity during the roundtables to get your voice heard, but I'll also take written questions at this point as well. So if you don't actually want to stand up and ask a question, very happily take a written question and I'll ask the panel for you on your behalf. Okay, so having seen the presentation there, may I ask if anyone's got any questions? I'm sure I saw lots of people writing things down, so I'm hoping you have. Yes, sir. Now, we're going to bring a microphone to you, and if I could just ask you to give us your name and if you're in any particular sphere, as in a councillor or just local resident or anything like that. Yes, sir.
Yes, I'm Dave Butterworth, and much to my surprise, I've just become one of the directors of Health Watch Oxfordshire, but I don't actually know anything yet, so I'm learning. This is a very simple question. I don't really understand what you mean by Phase 1 and Phase 2 consultation. I mean, are you consulting about the same thing and developing that, or are you consulting about different things? I just don't know what the terms mean.
All right, David, thank you very much. Who's going to tackle that?
I'm happy to do that. So we are consulting about specific things in the first phase or phase 1 of the piece of work. So they are, as we've been through, is those specific services around the acute bed changes, maternity services in the north of the county, critical care, stroke. Okay, those are specific changes that we will go through this process. We will listen to the feedback that's coming through the consultation. We will, the CCG will make a decision and implement on the back of that decision whatever changes we think are necessary. Then there is a further phase of work looking at the other range of the other services in Oxfordshire, which aren't covered in the first phase of work, and we will come out on that basis after that work.
And the second consultation timetable, I think you said, was it mid-autumn?
Yeah.
So that's phase 2 would be in the mid-autumn. Okay, any more questions? Don't be shy. Yes, let's just get the microphone to you there.
Okay.
What you were proposing to do from the Horton in the future sounds very good. I'm still not sure about the maternity bit, but never mind. Is the money available to do that?
Lovely. And sorry, your name is well?
Sheila King.
Sheila, brilliant.
I think I might pass that question to me.
Well, don't pass it too much down.
No.
Otherwise
So
you'll have me answers it.
So you'll get it back again.
The short answer is yes. So the actual there are the cost of the new models of care are very similar to the costs of the existing models of care. So the short answer is yes. Yes. Yes, and I suppose just to reassure you, in terms of the capacity, so it will mean some more work coming down to us. So in critical care, we are expanding the number of critical care beds at the John Radcliffe and at the Churchill Hospital, and in fact we'll be opening more beds than the number of beds that are used currently at the Horton for level 3. For stroke care, we are expanding the number of beds. Also, one of the benefits of the stroke proposals are that we are currently running a service as a pilot, or have been running as a service as a pilot, called the Early Supported Discharge Service. So that's something that Julie mentioned, that you get very good results if the patient is seen as soon as possible in a hyperacute specialist stroke unit, but then that you continue their intensive rehabilitation as close as possible to their home. And that is what the Early Supported Discharge Service does. That enables us to get patients home much sooner and much better rehabilitation. At the moment, that Early Supported Discharge Service, because it's been run as a pilot, is only available in certain areas within the county. Under these proposals, that gets extended to the whole of the county. So again, that's a benefit for the whole of the county. So those facilities will be expanded. And then finally, again, to reassure you, we've had to take measures, short-term measures, to expand capacity for maternity patients because we've already had to make these changes for maternity services at the Horton, because essentially we found ourselves, we need 9 middle-grade doctors, 9 doctors to run the service at the Horton. We found ourselves at one point with just the prospect of 2. So for that reason, we had to introduce these proposals from October last year. We've undertaken measures to expand capacity, so that means increasing delivery rooms. We've brought in a mobile operating theatre to give us more capacity to make sure we can accommodate both the mothers and their babies. And were this to become permanent, there are further measures then that we could take to make sure we've got more than adequate capacity to handle the additional births at the John Radcliffe. So the timescales for the increase in the critical care and stroke will be instantaneous. So as soon as the proposal is made, then we can put in place, subject to the recruitment of staff for the Early Supported Discharge Service. So we can do that in a very short timescale. As I say, we've already got temporary additional capacity for maternity. It will take, I couldn't give you a figure to do the permanent maternity changes. It would probably be somewhere in the region of 6 to 12 months. But that doesn't matter in as much as we've already got the additional capacity through temporary measures such as a temporary additional theatre and the conversion of other rooms to enable us to provide the capacity for women and their babies.
If I could just add one thing to that, which is just to do the maths with you. We're talking about 3 to 4 extra people a day having to come down to Oxford for Banbury. We're talking about somewhere in the region of 250 to 300 people a day being seen at the Horton who currently are driving and parking in Oxford. So from the South Oxfordshire residents' perspective, that should be 250 fewer cars a day trying to park in our sites, which might be welcome.
And just to outline, Tony, what sort of things will those 250, 300 be going up to North Oxfordshire for?
So there'll be first appointments with specialists, follow-up appointments, a whole range of day case activities, including day case surgery. We're already developing things like renal dialysis, blood transfusion, chemotherapy, but all of those sorts of options are extendable to increase the volumes of that kind of work.
Great, thank you. Any more questions? Yes, a gentleman there just with the white shirt by the door.
I think you're assuming everybody's got a car to transfer between the two hospitals. What provision is there for those that haven't got cars and have to travel?
Okay, sorry, and your name, sir?
It's Andrew Hall.
Andrew, thank you. Provision for those in without a car.
So, in terms of are you referring to the specific changes we're talking about here, or more generally in terms of people getting accessing services?
People coming from South Oxford up to Banbury, but they have to travel.
No. So let's be clear. So the figures that Dr. Barrett were quoting, there are currently around 120 patients, 150 patients, 1,500 patients, so 2 or 3 a day, who will have to travel from the Horton down to Oxford. The 90,000 that will be going the other way are patients who live in the Banbury area who are currently having to go to Oxford, who will be able to get their care much more locally in Banbury. So there's no change in the location of where people from this part of the world will be receiving their care. We're not asking people from this area to go up to Banbury. You'll still be, as Tony says, hopefully be able to access the Oxford sites a bit more easily, because there'll be these 250 to 300 patients who will no longer be coming down from the Horton.
That's clear? Yes. And the lady next to you in the red scarf, please.
Hi, my name's Alison Rook. I'm a county councillor here in Abingdon. I've got 4 questions, so if I could just ask all of them. Sorry. First is more of a comment. Clearly, from what you're saying, there's going to be much more of a reliance on community hospitals, and you talking about the EMU in Abingdon. So I'm just asking that when you get to phase 2 and you're talking about community hospitals, bear in mind places like Abingdon with an increasing population, we need to keep our community hospital. You said in your preamble, one of you, that you currently don't have enough staff for the current service now, so things have to change. But you acknowledge in your document that it's very difficult to recruit GPs, and loads of surgeries have got vacancies for GPs and other practice staff, and indeed home carers, because it costs so much to live in Oxfordshire. But you give no detail really about how you're going to achieve this, and the whole of your plan is dependent on having sufficient GPs, sufficient practice nurses, carers at home, and so on and so forth. And then also, just finally, as we know, there are increasing demands on A&E year on year, increasing number of people going to A&E. And there are cases of blockages in A&E effectively because they can't get moved on if they do need to go into the acute hospital because there aren't sufficient beds. So your idea of making the temporary bed closures permanent, or at least all of them permanent, how do you equate that with having the blockages in A&E because people can't get moved to acute beds?
Okay, thank you very much. I should have made that 3.5 questions, but I think that the middle 2 were a bit related. So, community hospitals and phase 2 with the increasing population. Who's going to start with that one then? Julie?
Yes, I mean, it's been a major preoccupation of my locality because of the huge housing growth in South, I should say our locality, because of the huge growth of population that's planned right across the Science Vale area and including around Abingdon, and there's a lot of planning going on at practice level at the moment about how to respond to those challenges. I think your point about primary care being under strain is absolutely right. But again, there are already ways in which practices are beginning to innovate, respond to these challenges. It's not easy. No one's pretending it is. And all the issues around what the future of community hospitals, how they're going to be fit for the future, and primary care is subject to the second part of the consultation. And of course, this does, as you rightly say, underpin a lot of the presumptions and plans within the phase 1 of the consultation. But those proposals and preparations work is underway on those already. So there's pragmatic things happening at the moment, and there are plans as well being worked up for the second phase of the consultation. So I have seen already some examples in primary care of how practices are diversifying, they're introducing a skill mix, they're having a good think about how things can be done differently, they're offering different ways of consulting with patients. So I think that it's not all doom and gloom. I think we have to stay positive and look at what we can do.
I'll just add to that, and as we start working through the rest of your questions with a bit more about the issue of workforce. We've got to be clear that's a huge challenge for us, particularly in this part of the world with the cost of housing. It's going to be challenging with things like Brexit, where we really have no idea how that's going to play, but I think we're all very nervous about that. But we have to start from the position of trying to get our whole health system treating the right patients in the right place in the right way. We can then advertise jobs that are sensible jobs where people are doing the things that they thought they were going to be doing. So to give you an example of why we took the steps that we did to release a whole chunk of beds in the hospital temporarily, what's now being consulted on to make that permanent, we did that because we had hundreds, literally in the John Radcliffe, nearly 200 people who were trapped in the hospital because we could not move them through into more appropriate places to be cared for. We couldn't get them home. We couldn't get them into what we call intermediate care, where they could have physiotherapy and some care, but didn't need an acute hospital environment. Now, to hire nursing staff for acute hospitals to look after people who don't need to be in an acute hospital is a waste of those people's skills, as well as being a really bad experience for the patients who were stuck there. On the other hand, to hire people who want to do home care and want to reach into nursing homes where we have what we call these intermediate care beds, where people are getting extra physiotherapy alongside the nursing home staff, that's turned out to be actually quite an attractive job for people. And we have been quite successful, despite being an acute hospital, as a provider in that sense, and in being able to hire people into teams that we've been developing that do this kind of work. And I think the impact of that, as you saw in a couple of cases on the video, but actually as we've seen in the patient satisfaction surveys that we've done since bringing this in, has been really profound. It's been hugely well received. It's been fantastic for our relationship with many of the nursing homes. We've come to understand that many of them actually are staffed by really motivated, humane, interested people who want to improve their skills, and it's been a great way of doing that. And it starts to move us towards a vision where folk who are in a nursing home actually can still be looked after with quite a degree of sophistication there, and are not just there to be a term that has been used in this sort of general territory in the past, warehoused, as it were. They're not being just put there to be stuck. They're being put there to have meaningful lives and stimulation, and when they're less well, some means of looking after them. So I genuinely believe if we can get the shape of the system right, with the right kinds of patients getting the right services in the right place, I really think we will be able to recruit staff who are motivated to do those different things. The other nice thing about doing this as a whole system, jointly with Council, jointly with Oxford Health, who run a lot of the community services as well, is actually staff who work in that joined-up system, I think, can also potentially see a joined-up future. They can see how they might begin in one place but actually be able to progress their careers through into other sectors. So I do think there's really an exciting vision that we are working towards realising here. And I think just to come on to your point about the release of the beds and the front door and the linkage with that, just to be really clear, the beds that we've released so far were beds that were entirely occupied by people who no longer needed to be in hospital. In that sense, they were not part of our acute flow. They were simply unavailable to people who needed to be admitted. Now, it's probably true to say if we open 200 beds tomorrow, for a week or so, there would be no problem getting anyone into hospital because there'd be some empty beds. As soon as those beds were full again, we would actually be back to where we were, because our problems are how do we look after people when they don't need to be in hospital, and we would just reinvent the same problem as we had before, only with more people in hospital, hiring lots of agency nurses to look after them, not as satisfactorily as what we can do at the moment. So I think there is not an absolute linkage between those beds and the pressures on the front door. The problems we've had in Oxfordshire have been actually much better than in lots of other parts of the country. So we watch the news and see what's going on in Blackpool or somewhere and think, well, it must be that bad in Oxford. It has not been that bad in Oxford most of the time. We have had some pretty awful days, though, so I'm not pretending it's perfect.
Andrew Stevens.
I suppose I think one of the messages we've heard, and I think we need to go away and reflect on from sessions such as this, is that we haven't been as good as we might have been in describing the models of care and some of the models of care that don't rely on beds. I think traditionally people have looked at beds as a measure of activity and of resource, and I think we need to get much better. So if you'll forgive me giving you some figures, to try and help us in this process, we did a snapshot on the 5th of February. We just took a data at random and tried to look at the number of patients we were supporting. So that's us as a trust. And, people think of us, oh, yes, your bed's at the John Radcliffe, your bed's at the Churchill, your bed's at the Horton. But so this is us as a trust and the number of patients we were supporting in non-bed-based services. So we had 160 patients who were going through the model of care that Julie described, where they were coming either to the John Radcliffe or the Horton and being seen on a day basis, assessed, treated and sent home on the same day. We also had around 100 patients, as Tony mentioned, in private nursing home beds, but getting that enhanced support from doctors, from therapists, from nurses, enabling the nursing home to look after patients who are iller than the sorts of patients they would normally look at. Again, patients who are being seen closer to home. And then we had another 220-odd patients who were being looked at by our supported hospital discharge team and our reablement teams. That's over 500 patients who, if those services weren't there, would almost certainly, the vast majority of those would have ended up in a hospital bed. So it's that sort of new model of care that we're trying to move towards, in partnership with social care, with GPs, with our colleagues in Oxford Health.
And sorry to add, we must feel you're being talked at, so very quickly, the resource, the human resource to make those new services for those 500 people work came from the beds that were released. So with the savings that the Trust made, 4.8 million went straight across into providing for those other services.
So the amount of money from one went straight into the other. There was no... Right. Okay. Any more questions? Or does anyone have a written question they'd like me to take in? Lady in fuchsia pink.
Hilary Davies, my name. I wonder if you could just answer a question for me, because I just don't understand. You say you're going to do all this, but I was reading an article the other day from a Janet Davis, Chief Executive of the Royal College of Nursing, and she was saying that you're going to cut nurses, paramedics and doctors. Now, is that true or not?
Hilary, can I just check, was that, when you say you're going to cut, was that specifically aimed at Oxfordshire or was it across the country?
I don't know, but we keep hearing of nurses being, there's not enough nurses. And then the next minute you read, we're going to cut 200 nurses. Okay. Does that, what is that, what do you actually believe?
Okay, well, we've got the man himself to answer that. Andrew Stevens.
I suppose I'd want to start off by repeating something that Gareth said. Our money isn't actually going down. It's not going down, but it's not going up fast enough to keep pace with demand. So what we're trying to do is to develop new models of care, as we've just described in the answer to the last question. So it's not a question of necessarily cutting staff, but it's trying to deliver more care within the resources that we've already got. And so getting those resources, as Tony said, into the right place, so we're not wasting time by patients staying in acute beds when they don't need acute care. There are not delays between us discharging patients to social care or between one set of professionals and another, that people are working in a multidisciplinary team. So it's not about cutting care. We're not cutting our staff numbers. And what we are trying to do is change our staffing structures so that they are enabling us to provide more care within the same resources that we've got. And the examples we just gave around closing acute beds and putting that money into either day treatments or into community-based care or care to support people in nursing homes enables us to do that.
I mean, we've over the last 2-3 years employed hundreds more nurses, partly because we've stopped hiring agency nurses and encouraged people to come across onto permanent staff or through the NHS bank, as you'll be aware of that national initiative to do that.
Okay. Yes, it's pink. It's a run of pink.
Hello, my name's Emma. I'm with my team here, work in the emergency multidisciplinary unit in Abingdon that you've been referring to quite a lot this evening. My question, or possibly statement, is around the fact that we are exactly pioneering the sort of ambulatory pathway that you've been talking about. However, it's not going to work if we haven't got the infrastructure to support it, particularly with regard to frail older people, enabling them to come to us and having an appropriate transport service for them. And in the recent clinical commissioning of transport for the whole of Oxfordshire, our dedicated service was actually taken away, which has quite significantly affected how many patients we can serve in the way that you're describing. And I just wondered, with probably phase 2, whether that will be revisited and resources put back into that to allow us to see the numbers of patients that we could, enabling them to be prevented from admission to the acute services.
Emma, thank you. For those not in the know, ambulatory does not mean ambulance, it means walking in to somewhere effectively. Sorry, just for my simple mind. So transport and that issue about being able to use these great services being provided by that table.
So I can respond quite quickly. So I think from what you've said, there's been an adverse impact of a change we've already implemented. So I think what we need to do is speak to you outside of this, but take those issues and see what we can do within the existing contract arrangements we've got for the patient transport services. So we need to link up to try and do that. And then straightforwardly in terms of will we consider it in phase 2? I think yes, absolutely. We would have to.
Okay.
And can I just say I'm really pleased you're here, so some of the public can hear it straight from someone providing it rather than a manager. I know we always like to hear from the front line.
A lady at the front here, yes.
Hello, Fiona Mackay-Perkins. I'm a resident in Oxfordshire and in Abingdon. I think, Dr. Brent, you sort of touched on it when you talked about beds becoming free, but I just wondered, with these proposals, are they going to start to tackle the area of patients being delayed from leaving hospital, particularly where they need care packages? Because one of the areas that I've been personally involved in recently with family members is once they go into the acute sector, the most difficult aspect, even with family trying very hard to get them out of hospital, is getting them out. And I know you said you weren't going to call it discharging, but there has to be some recognition that Oxfordshire's had some real difficulties in discharging patients from the acute sector. And I just wondered how these proposals were going to impact that, and whether you could explain that, please.
Yeah, of course. Andrew will probably come in after me. I mean, so the answer is they already have, and much of the bed release programme was put in place precisely to deal with the delayed transfer issue. Now, I think what you're touching on is in part that even if you can get people into the nursing home sector, intermediate care beds, more rehabilitation, that doesn't necessarily mean that you've then got packages to get those people to home. What you can, however, achieve is by moving people faster into those beds, they are not spending time in the acute hospital deconditioning, to use a sort of dreadful word, getting less and less fit as they sit in a chair, don't get quite the physio, or, almost as bad, get up and mobilise in an unfamiliar environment and at risk of falling over or having something else happen. So there is, the notion is that you can move more quickly to a place where rehabilitation is more likely to be successful, and that ultimately a bigger proportion of them will in fact be able to get to home with or without a package. Now, we've been tracking the figures initially just from a safety point of view to check that the expected levels of hospital readmission, death when in the nursing home, eventual discharge to home, eventual nursing home placement looked to be similar to what was happening with a group of patients who had, were stuck, if you like, before the programme began. And we've been very reassured about that in terms of the figures. I think what we are looking for in the long term is to see whether we do get the kind of improved outcome that we're hoping for. You are absolutely right that in the longer term, for this to really work, we need yet better ways of looking after larger numbers of people in their own homes. And I think that's going to be a tricky one. Philosophically, we might say, well, maybe ultimately we need to release even more beds in hospital because we've still got 100 or so people stuck. When we began the programme, there were nearly 200 people as delayed transfers. And when it was first introduced, and you can imagine there was a very rapid movement of people out. We got down to nearly 50. It's swung around since then and gone up to above 100 and oscillated around. And that's partly, I think what we've been learning is that you don't necessarily know at the beginning exactly how many beds you need in the intermediate care bed sector, as it were. You don't know exactly how many hours of domiciliary care you need. And so, if you like, the system as a whole is kind of working out the new balance as it goes along. We are also doing some work to try to actually see if we can predict this slightly more reliably. What we are looking to longer term is to further expand the domiciliary provision, not on a permanent basis because we wouldn't do that, but with the short-term help that we can provide to get people through. But I think, in a way, part 2 of the consultation is also part 2 of this piece of the conversation, and I think we're all on this side of the table committed to getting the council involved in part 2 of the consultation, because we really have at that point got to start looking at how we're joining up health and social care for this particular bit. There's one other bit which is also a sort of slightly uncomfortable message, especially for people in this room who are already doing tons to support older relatives, and that's, as a society as a whole, we might have to think about whether we actually can ever have enough people for older people not to need more help, on average, from people who they know, as opposed to people that we, as a state, as a society, hire. But that's a different one, and that's nothing to do with this consultation. That's just a kind of uncomfortable message for some of us to have to start to think about. And I speak as somebody with an 85-year-old mum, who's got her own difficulties, so...
just the people who are by the bar, as it's getting noisier, you can still hear us okay? Yes, right, okay. No, it just seems to be getting a little rowdier as the evening goes on. Okay. Yeah, do you mind if I just see if there's anyone who hasn't asked one yet, and then I'll come back to you, sir. Is there anyone who's not asked a question? Yes, there's a lady here with a black scarf. Yes, please. Sorry? Not pink. No, you've broken it. What can I say?
I didn't know the dress code.
You didn't get the memo?
No. I'm Fulya Markham. I live here. Just a simple question, really. Maybe the answer is yes, of course. But what happens if a mom starts being low risk and becomes high risk, as we know it can happen? And it doesn't apply to hospitals only. It can start at home, etc. So will they be transported to JR by ambulance, or how will that work?
Okay, thank you very much. And sorry, your name?
Fulya.
Fulya?
Markham.
Okay. And do you mean from this area of Oxfordshire or just generally in Oxfordshire? Yes. Who's going to tackle that?
So this happens all the time because with the best will in the world, there are women who are deemed to be fit and healthy, who are suitable in every way to have their child in the midwife-led unit, and then something happens during labour and they need a transfer. So, as I said before, the warning signs are generally there early enough that you can arrange a transfer very quickly with an ambulance, with a midwife attending in the ambulance with the mother if needed. And so I think that there's going to be no difference in terms of this situation applying for women from the north of the county, as happens already from places like Farringdon, Wantage, Henley and similar areas.
Okay, should we go back? Any other questions? Or should we go back to the gentleman who asked one of the first ones? The gentleman here with the scarf again. Yes, please, sir.
Yes, if I may. The picture you've painted...
Could you just get the... That's it. Yeah.
The picture you've painted is one of restricted funding, anyway, which leads to, I suppose, restricted resources, combined with an increasing demand. Now, in the long term, that's an impossible thing to deal with. Now, you've suggested, I've heard two ways from you of how you're going to deal with it. One is you're getting cleverer in how you're doing things. You're having to think harder about it. The second one is increasing technology. Now, I just have a feeling that those two are not going to be enough. And I don't know whether you all believe that or not, but it doesn't seem to me that it will be enough. Another thought I could throw in is the voluntary sector. We have a huge voluntary sector in Abingdon, over 200 groups. And, all right, they're not going to be able to do operations, but they can keep people well, can stop people having to go into hospital in the first place because of well-being. There are over 200 groups in Abingdon, and I'm looking to ways to get them to work closer together on ideas of health and well-being, and also, to collaborate more and to have collaboration and help from the hospitals, the CCG, and so on. And I think there needs to be a greater dialogue in that area. There is one area I can perhaps mention that is a big one, and that's the Oxford Hospital, the Oxford Health Trust, where they have the Oxfordshire Mental Health Partnership, where that is mostly run by voluntary groups. So there is a template there that you could look at, and also another template that I'm working on, which is one specifically for the town of Abingdon.
All right. I think just on that point about funding, we obviously over the period of meetings have invited various MPs. It's obviously we can't talk about the funding from the government because that's nothing really to do with the panel. But on that point, I think that it's fair to say the money is increasing, but not in step with demand is the basic bottom line. But we get the gist of your point. But regarding regarding working with fantastic voluntary organisations here in South Oxfordshire and the ones that you've highlighted and no doubt are part of, I don't know. Does David what? Right? Can we get the microphone because we have a mystery guest here who is not on the panel, but is the man that we need to speak to. And then I think Andrew wanted, yes.
Thank you. I'm David Chapman. I'm a GP in Oxford, but I'm also the mental health lead for the CCG. And I was very much part of the team that developed the partnership around the Oxford Mental Health Trust. And what you say is absolutely vital. We have these wonderful third sector partners everywhere, and we realised when we were developing the mental health programme for adults in Oxford that we asked patients what they wanted. And the outcomes that they wanted, of course we had very good sort of mental health team and doctors and CPNs, nurses, but actually the things that people wanted in the mental health trust were delivered by the third sector. And we thought, well, those are the bits that add the quality for our mental health patients with mental health problems. Why not incorporate them into the whole partnership? And this generated a huge, very dynamic process. And we realized what a great value the third sector offered. And we are now looking at this across other parts. So we have Age UK closely involved with care of our dementia patients in Oxfordshire. And we have Age UK delivering things like generation games, which is how you develop falls preventions. And there's a lot more that could be done incorporating our acute sector. In Warwickshire, for example, Age UK are intimately involved in discharge of patients out into the community, and we need to develop structures just like that. So the CCG, and I'm sure the Acute Trust, and I know Oxford Health, who are here as well, are very keen to develop these third sector bonds, and that's one of the ways forward we have to look at.
Thank you, David. And Andrew?
I mean, just really to build on that. So in the presentation you saw on the different use of beds, Age UK and their Circles of Support initiative have been very much part of that. I think the other thing I think I've learned from these presentations and these meetings, we were in Wallingford, and I was on a table with a group of people who, as well as these specific help in specific groups of patients, be they patients with mental health or elderly patients, were pointing to the sort of geographic community networks of support. So the table I was on, a gentleman described an absolutely brilliant scheme in Cholsey around how people, home visiting, support, neighbourhood support sort of networks, we could mobilise those to help make sure that people get access to the services that they need quickly. So that's certainly a lesson I've taken from the sessions we've been doing around the county.
Okay. Any further questions, or shall we break into the smaller round tables? Okay. So, for the round tables, basically there will be a member of the NHS team with you. And what we'd like to do is really get an answer to 4 questions. And if you've been a bit too shy to stand up, here's a great chance to make sure your voice is heard, because all these notes are taken in afterwards. So the questions that we want answered are, has the need for change been demonstrated? Has the need for a change in the NHS been demonstrated? What will the effects be on you and your family? A third one, what do you think has to be done, or has things been put in place to mitigate that effect, or what could be put in place? And therefore, lastly, your proposals and suggestions, anything you think the panel hasn't thought about or this consultation needs to tackle, suggestions, as we've had from the lady about, I've forgotten her name, about... thank you, Emma. About the transportation in your particular case. So we'll break into round tables for, say, 20 minutes, half an hour, and then hear the main points from each table. So, shall we have a little break there? Yep. Okay. Okay, we almost all done? Pretty much all done? Another minute or two there. It's just that we've only got the room until 8:30. So another minute or two and then we'll wrap up. Okay, I think we'd better finish it there if we're to finish on time. What I'll do is just go to one person on each table just to give me like a minute of the top 2 or 3 things that have come out. Then we'll hear from a couple of the panel members, I think, as a conclusion maybe, and then we'll wrap up for the evening. So in a clockwise rotation for me. Gareth, what were the main points on your table, please?
I better get this right, I think. Pressure's on. So I think we had a lot of discussion around the case for change, both the broader case for change and the specific ones around the proposal we're talking about. So I think the summary is there's understanding of the case for change around the critical care proposals, the stroke proposals, and even the maternity proposals. I think where there is more concern is around the proposals around the acute bed changes, and this makes the link between the phase 1 and the phase 2 pieces of work. So there's a desire to understand more in terms of the how community services, how primary care services are going to change to support more that model of the bed changes. So that's the first point. And the second one, there's a real clarion call from the table, which we've heard before, is the need within the phase 2 work to address the key question of integration. That's integration of healthcare services, but fundamentally integration of health and social care services. To get that right. Is that?
Brilliant. Okay. From the table in the corner there, Lorcan, if I could just ask you, because it's getting a bit rowdier next door, you just keep the microphone nice and tight.
Can you hear me clearly? Yes? Thanks. I think it was broadly accepted that there was a case for change. One of the points made was, why, if we knew this, or if we know this, why haven't we made some of these changes even sooner? Which I thought was a fair point. The point about social care integration was a concern, and perhaps the NHS ought to be doing more of the social care elements came up as an issue, or as a point rather. Around the sort of mitigation of impact, don't we still need more money for services to meet the rising demand regardless of change? One clear point was that there was a need for clear signposting through services and assistance for people throughout that process, so they didn't feel they were dealing with lots of new systems but were guided through. And some concerns that maybe the changes might bring extra pressure on carers, but also people like the idea of diagnostics closer to home. Some of the outstanding issues, I think, were around public transport and availability and access.
Okay, thank you very much. And David on this table here, who we heard from a little earlier this evening.
Yes, so there was a general view that a bit of concern that there were these two phases, and how could we make a judgment on phase one when we didn't really understand what was going to happen in phase two. So that was a general comment that we discussed. There were some concerns around travel, particularly around, I suppose, loosely intra-part-time care. What happens if you're in labour and travelling? So there were concerns for patients in the Horton having to be transported down there. And we didn't really talk about it on the panel, although I know at other meetings we have talked about it. But that was a concern. There was one concern that at the moment, for example, if you want to get your hernia done by the OUH, actually you have to go to the Horton to have that done now, which has been inconvenient for patients in this area. And the concern was, are other services going to be moved from the JR to the Horton, which will affect patients in this area? In general, though, the idea of freeing up space at the JR from the perspective of people in Abingdon and the south of Oxfordshire seemed to be a good benefit of these changes, so we're supportive of that. There were other concerns around journeys for the frail elderly and other transport issues which were raised here. And one impact which would mitigate these changes is around parking at the JR and having multi-storey car parks and having maybe some sort of intermediate stay, like a sort of Premier Inn where people could stay as a step down, which would be cheaper and better than spending £500 in a hospital, was raised. And of course, if there were changes that happen, would we have the right community services in the local area to support these changes? And again, that's the phase one, phase two argument. We don't quite know what we're proposing for local services in Abingdon, so it's hard to be totally clear. We're a bit worried about we agree totally with the voluntary sector concept and increasing that, but we're a bit worried that circles of support, for example, has now had funding withdrawn by the CCG, at least on a temporary basis. So there's some concerns around that. But also some idea that local areas should be deciding what services are needed here. And again, that may be a phase two, phase one issue, but was raised here. So I think those were the main points that came out of our table.
Thank you very much indeed, David. Almost there, two more to go. We'll go to Pete, who was very kind nipping out. It was actually a burglar alarm that went off, apparently. It wasn't the fire alarm. Peter McGrain is from Oxford Health. Peter.
Hey, thanks, Gavin. We find ourselves in this sort of a strange situation, actually, because virtually everyone on the table, bar this lady, actually, we're all sheep-dipped, really, within the NHS. So perhaps we had a
I bet you got a shock sitting with that, lad.
Yeah. But, so broadly, a lot of comments, actually, that we would echo, actually, with previous people who contributed. I think when we talked about whether we've made the case for change, I think broadly there was a consensus, actually, that we have made the case for change, particularly in relation to the phase one, but there were similar comments that were raised about phase two and what that might mean. Broadly, it's made, but possibly we haven't been as brave in terms of making the case quite forcibly. Madeleine reflected that there's probably more that we could and should do about stating what the obvious evidence says. You know, that if you want good outcomes, you go to the people who can who are rehearsed and experts in the delivery of that. So we talked about if you have a Peugeot car, you go to a Peugeot garage and you go there for a reason, because the outcomes are going to be better for it. And exactly the same is true with a lot of critical care and things like that. And we're probably just not brave enough in terms of standing up and saying things like that. A lot more that we could do in terms of getting the positive stories, because some of the fear, I think, that people have is that it's all about finance and that a change, because you have to protect and you hold on to what you've got. But maybe if we're more clear about having positive messages out to the general public about celebrating the successes that we have, that we may get past some of that initial sense of fear and frustration amongst the public. The other thing we talked about in the table was about how we need to be careful in terms of how we engage meaningfully with the general public for some of the challenges that we have. It's very easy for us to slip into talking about the challenge of the older person without seeing the success that it is a product of the success, because we have people who are living meaningful, healthy lives for longer now, and that we need to be really careful and mindful about how we engage with people in doing that.
All right, Peter, thank you. And lastly, Catherine, on this table.
So thank you. So actually, like Pete's table, we're all sheep dipped on this table. So we had a conversation based on people who work in the NHS and their perspectives. So a lot we had was it did, from what was presented, that it was clear in terms of making the case for change. But we then had a conversation about, is that, it was based on logic and facts and looking at it like that, but do we also need to think more for phase 2 about the emotional side of the presentation and think about how we talk about that? And because we have frontline practitioners on the table, they talked about, it is clear every day that they have the same number of staff, but the demand has been going up and up and up. So we need to reflect that. In terms of impact, it was a mixed discussion because the impact of this first phase is not as significant in this area. But we had some case stories about using of the local services, so using the EMU, how that then facilitated a smooth transfer into the JR, not using A&E. So picking up the point about using good examples to show what the services we're trying to plan look like. And I think the biggest issue that we were raising and discussing linked with the integration was recruitment and being able to continue to staff services of whatever model that they are and where the different challenges are.
Okay, thank you very much. So we've got 5 minutes. Do you want to just come back round to the panel? Now, I'm going to ask if any of the panel members want to sum up. I think there was one point that I think Andrew was very keen to address, just about there was the point about fear locally that they would now have to go to Horton for things they're currently getting at Oxford. So, Andrew, do you want to sum up first?
Yeah, so just on that one point, so none of the 90,000 patients are patients from the south of the county or from Oxford. Those are all patients from Banbury and the surrounding areas in South Northamptonshire and South Warwickshire who are currently coming down to Oxford for treatment, but who could be seen in Banbury if they were at the Horton, if the facilities are there. So it's not about people from Oxford or South Oxfordshire going up to the Horton. I suppose just quickly then, in terms of my summing up, I mean, I think it is the points that have already been made around integration, transport, the language that we use and how we describe. I think that the one additional point, and it may sound a bit fluffy, but I mean it sincerely, is it's the power in the room. And the ideas of getting members of the public who are interested, members of staff from all levels, from all disciplines together. And seeing that as a real resource in this process, I think, is going to be incredibly important going forward because, as people have said, you're the people who know what's happening locally, you're the people who know how the informal networks, you're the people who know how the local voluntary sector can help mobilise to support. And so it's going to be absolutely crucial, I think, particularly around the second phase, which is more about the community-based facilities, to really harness that energy and those ideas and that support. So, I really thank you for that. It's been, very energising for, I think, people like us coming to these sorts of events.
Okay, and Dr. Julie Anderson. Do you want to do anything, Tony? Or?
Yeah.
Okay, sorry. No. I was going to say ladies first, but actually maybe Julie should round it up. Dr. Tony Barron.
So I know it's been a very useful evening for me and lots to think about there. I think I probably ought to respond to the maternity thing because we've not had people contemplating, the direct impact for themselves or families living in Abingdon. We have not had the kind of force of questioning around maternity that we experience when we go to the north. But that doesn't mean that some of you might not be worried on the behalf of the people in the north. So I think what I'd like to make really clear is that what we're talking about is implementing something that is entirely endorsed by national evidence-based guidance, by NICE, the National Institute of Health and Clinical Excellence. the use of midwifery-led units in maternity services is well established, and the evidence is very clear that the outcomes for the baby are equivalent to the outcomes in the obstetric units, that's the doctor-delivered units, but the outcomes for the mother are better. The experience is better, there is less intervention. And that sounds, hard to believe if your assumption is it must be better if there's a doctor there. But what we forget is there's a group of women who are lower risk in terms of their pregnancy and their delivery, and those women do not need the attentions of a doctor. And if they get them, what happens to some of those women is more stuff is done to them than would otherwise have been necessary. And that's not because doctors are bad, but it's because we can't always control ourselves if we think that actually there's a bit of risk going on and why don't I just pop this monitor on, or even something like why not have an epidural rather than do all the interventions you could to manage the pain. We know having an epidural makes it more likely that you'll need assistance to get the baby out later. So, you medicalise the beginning part of it and you medicalise the end of it. So that's why they end up being in balance. And the evidence on that, which is based on tens of thousands of deliveries in big national surveys, is that even with this issue of having to transfer about a quarter of the women who start in an MLU, in a midwifery-led unit, about a quarter of them will transfer to the obstetric unit. But if you have the protocols right and the transfer is made early when it's clear that things are not progressing as expected and you're rigorous about that, then that is a safe process. And so the kind of fear that we encounter about this, that women will be giving birth in the back of ambulances, that terrible things will happen, is not what is played out in the evidence of tens of thousands of deliveries in midwifery-led units. So that's the model we're following, and what we're trying to explain to the whole county is, the evidence would say this is safe. We're putting processes in place to be confident it's safe. We're monitoring it. If it ain't safe in Banbury, it's also not safe in Wallingford, and we're happy it's safe in Wallingford. So, that's, and I know that's a bit of a response rather than what am I taking away. I do think this issue about how well we've communicated the need to change is important. For example, we're talking about getting agreement to close these beds formally. The beds have been released, as we call it, because they've not been closed with approval. We've not been using these beds we're talking about for over a year. We've been providing these alternative services for over a year. We've had over 500 patients go through those alternative routes over that period of time, and Andrew talked about that snapshot. So what we're asking for from the CCG and in the consultation from the community and the politicians is agreement to make that arrangement permanent. We're not asking to start something new at this point. It's been done, and it, as I've described, has had some impact, not full impact, but some impact on the delayed transfer issue, and clearly an impact on a whole group of people who didn't need to get admitted to hospital. So, as I say, I think it's been a very good conversation from my point of view, and thank you very much. And one final point, because you sit down at the table and you hear people saying, oh, Dr. Barrett, this from other tables. If anything I've said sounds like a load of rubbish, please challenge it and come and talk about it, because I'd hate you to leave if I've not made myself clear or there's been a misunderstanding and us not have a chance to clear that up.
And just briefly, because we have slightly overrun, Dr. Julie Anderson.
So we've heard a very diverse range of opinions and concerns this evening, and that will certainly inform and flush out the consultation process. All these comments will be assimilated and proceed into the final document that will support the proposals and the formal endorsement of them. Interesting that this table felt that our presentations perhaps weren't positive enough. We weren't making enough of a case for the benefits of what we were doing. At the table I was at, they were saying, it's all sounding a bit too positive. There must be some downsides. So, as I say, I think the diversity is something that we appreciate in terms of consulting with you. So we're grateful for that. The other thing I've been struck is just how a lot of your comments actually are really useful comments in us thinking ahead to the second phase of the consultation. And so quite apart from the first part, you are helping form our thinking for the second part. So I'm grateful to you for that. Very grateful for your turning out on a Monday evening in back end of March.
Thursday.
Back end of Thursday, March.
Someone's stuck in a time warp. Okay, on that bombshell, just to say, because we have run over on time, don't forget, at the back of the pack are ways of getting in touch. It hasn't ended here, but it will end on the 9th of April. So the consultation comes to an end on the 9th of April. Please do get in touch via the ways there. Royal Mail, telephone, social media, emails, all the rest of it. It's all there. Thank you and good evening.